Okay, now let's talk about respiration and artificial ventilation. Airway is one piece of the puzzle, and then we move into breathing. So we're going to look at the physiology and the pathophysiology of respiration. We're going to talk about positive pressure ventilation that you would provide as an EMT with a bag valve mask. We're going to look at oxygen therapy, some special considerations concerning respirations, and then assisting with advanced airway devices. Now, ventilation is a process of moving air in and out of the chest. And ventilation is both an active process and a passive process. The active process of ventilation requires energy. During the active process of ventilation, you inhale. The diaphragm flattens, the intercostal muscles contract, pulling your chest upward and out. The pressure inside your chest becomes much less than the pressure outside in the room, and air rushes into the chest to fill the lungs. Works a lot like a billows. And that's just what I talked about, inhalation. Because it is an active process, it does require energy. And if a person has an increased work of breathing, if you look at them and they're working hard to breathe, at some point, if they don't get enough energy or the muscle itself just wears out. So when you see an increased work of breathing, we need to figure out what the cause is and provide therapies to improve their work of breathing as an EMT so that they don't quit breathing altogether. Exhalation is a passive process then. The muscles relax, the size of the chest decreases, and as the weight of the chest falls, it pushes the air out of the chest. Now, tidal volume and minute volume are terms that we need to understand concerning respiration and ventilation. Tidal volume is the amount of air that you move in one breath. Normally, it's between 300 and 500 milliliters of air in the average adult patient. Minute volume, then, is the amount of air you move in a minute. And let's say, for example, my normal tidal volume is 500 mils, and at rest I'm breathing 10 times a minute. Well, I would need to move 5,000 milliliters of air in 1 minute in order to stay alive. So minute volume is just as important as a breath. And what this leads to, or what I'd like you to take home from this, is that if I'm ventilating a patient and I get the chest to rise once in a while because I don't get a good seal with my mask, I'm not providing enough minute volume. It's not enough to make the chest rise once in a while. We have to make the chest rise each and every time we ventilate them in order to move enough air in 1 minute to keep them alive. Now, dead space air is the air that is moved in ventilation, but it never reaches the alveoli. This includes air in the trachea, air in the main bronchi, air in the mouth and nose. It's there, but it never actually gets into the alveoli. And that's typically about 150 milliliters and remains constant. Alveolar ventilation is the air that actually reaches the alveoli for gas exchange. So from my normal 500 milliliter tidal volume, I have to subtract from that 150 mils of dead space air, which leaves me about 350 mils of air that actually plays in the gas exchange. Now, the exchange of gas occurs through a process known as diffusion. And during diffusion, gases will move from an area of higher concentration to an area of lower concentration in order to equal those gas pressures out. So if you remember back when we were talking about the alveoli and the capillaries and how the red cells march single file through the capillaries that surround the alveoli, that's where the exchange of gas takes place. When I take a breath in, my alveoli have a higher percentage of oxygen than the capillary red cells that are passing by the alveoli. So oxygen will leave my alveoli and go into the red cell in the capillary beds in order to oxygenate the body. The same holds true with the red cells coming back from the body that are full of carbon dioxide. When they get to the alveoli, those red cells, the carbon dioxide moves off the red cells and into the alveoli, and then we exhale that and start the process all over again. So external respiration refers to the diffusion of oxygen and carbon dioxide between the alveoli and the circulating blood, where internal respiration refers to the exchange of gases between the blood and the cells. Now, anything that obstructs the airway is going to affect external respiration. Anything that prevents the chest from rising or prevents inhalation is going to affect respiration. Anything that puts a distance between the alveoli and the capillary, like pneumonia, like blood, anything that puts a distance between those capillaries and the alveoli will affect respiration. Internal respiration, as we had mentioned, is the exchange of gases between blood and the cells, and that's known also as offloading. And things that affect the oxygen's ability to go into the cell include things like your body temperature and your pH. The more acidic or alkalytic you are, the harder it is for oxygen to get into the cell. The colder you are, the harder it is for oxygen to get into the cell. Now, cellular respiration is when the oxygen from the blood goes into the cell and the carbon dioxide from the cell moves into the blood. So there are several types of respiration that we need to consider when we're assessing a person who is having difficulty breathing. Now, the cardiopulmonary system refers to the heart and the lungs. It's one thing to have the lungs as a place for the exchange of oxygen to occur, but you need a pressure to push that blood through the lungs, and that is done by the heart. Anytime the mechanics of breathing are disrupted, if you have a hole in your chest, if you have a spinal cord injury that prevents your diaphragm or your intercostal muscles from working, anything that, again, puts some distance between the alveoli and the capillaries, blood loss, not having an adequate number of red cells, all those things will affect gas exchange. The brain and the body needs a steady supply of oxygen in order to function, particularly the brain. Now, some of your tissues, like your arms and legs, can go hours without a blood supply, and those cells will do quite well. The brain, however, has no capacity to store oxygen and utilizes oxygen a lot in order to function. It's estimated that the brain uses about 30% of all the oxygen and sugar that you take into your body just to function. Anytime that your brain or your body cells don't receive enough oxygen, that's called hypoxia. Hypoxia is low oxygen levels in the cells. Hypoxemia is low oxygen levels in the blood. Now, carbon dioxide must also be removed. If carbon dioxide isn't removed, it combines with water in the body to form carbonic acid and can cause acidosis in the body. The term that describes high levels of carbon dioxide in your body is known as hypercapnia. And we'll learn that you can use, as an EMT, a pulse oximetry to measure oxygenation, and you can use a end-tidal CO2 monitor to measure ventilation, or to measure whether the carbon dioxide is at the right level. We have to be able to assess the patient to know whether or not they're breathing adequately or they're breathing inadequately. And so for us to assess adequate breathing, we need to know what that looks like. One of the things that a person will do when they are having trouble breathing, or they feel that they're having trouble breathing, is complain of shortness of breath. They say that that's a symptom, and symptoms are something that the patient tells you, where a sign is something that you will see. So what we'll see in somebody who truly is hypoxic or hypercapnic is an increase in the respiratory rate and depth, as well as an increase in their heart rate. All of those things are the body's compensatory mechanisms in order to provide oxygen to tissue that isn't getting it. Now, early on, steps of adjustment can meet the needs of the body despite whatever the challenge is that's causing the respiratory distress. Your body can compensate, but like all compensatory mechanisms, they're short-lived. You can only increase your rate and depth so much, and if the needs aren't being met by that compensatory mechanism, eventually you will become hypoxic. Now, respiratory distress is the term used to describe when the body compensates for a respiratory problem in order to meet the metabolic needs. For me, respiratory distress, I know a person is in respiratory distress because I can see an increased work of breathing. They tell me that they're short of breath. Perhaps their CO2 is high and their oxygen is low. But they're able to compensate in respiratory distress. Their compensatory mechanisms are able to supply oxygen to the brain. Now, inadequate breathing occurs when the challenge or the needs are too great for your body's compensatory mechanisms. This is also known as respiratory failure. It's really important to recognize when a patient is in respiratory failure because patients in respiratory failure will progress to respiratory arrest and then cardiac arrest if we don't intervene. Now, for me, I know a person's in respiratory failure because I see all those signs that they're working hard to breathe and their level of consciousness is altered, which tells me that they're no longer able to meet the metabolic demands of the body. And the first organ to show dysfunction when there isn't enough oxygen to go around is the brain. So if I've got a person who's working hard to breathe and their level of consciousness is altered, they are perhaps in respiratory failure. Now, respiratory distress usually involves accessory muscle use, an increased work of breathing. Severe or prolonged respiratory distress, as we mentioned, can lead to respiratory failure and then respiratory arrest. Just remember that in a patient who's working hard to breathe, at some point, they'll quit breathing. I liken it to taking a 10-pound weight and lifting it. And lifting it. At some point, you're no longer going to be able to lift that weight because the muscle itself is spent. You've completely run out of any energy. And the same holds true for people who have an increased work of breathing. So when we see an increased work of breathing, we see that patient in respiratory distress, we need to intervene. So signs of adequate breathing. The patient is alert. They're awake, their pulse ox is normal, their skin color is normal. Adequate breathing is difficult to detect because it is silent, it is shallow, it's just very difficult to detect. If the breathing draws your attention, in other words, you look at the patient and you can tell right away that they have an increase in their work of breathing, you know they're in respiratory distress and perhaps respiratory failure if their mental status is altered. So signs of inadequate breathing include chest movements that are absent, minimal or uneven, abnormal breathing patterns. You can't feel any air or hear any noise when you look, listen, and feel. If you listen to lung sounds, the breath sounds are diminished or absent, and you may hear some sort of sound as they're breathing. Remember, noisy breathing is obstructed breathing. Wheezing would indicate lower airway obstruction. Crowing or stridor would indicate upper airway obstruction. Gurgling would indicate fluid in the back of the throat. Or gasping during breathing is a sign of cardiac arrest in somebody who does not respond. Their respiratory rate may be too slow, maybe too fast. They may be breathing very shallow or very deep, and they may be working hard to breathe. If their red cell count is adequate and they have enough blood volume, they may be cyanotic. Inspiration or expirations may be prolonged depending upon the respiratory disease that they have. In patients who have asthma, it's very common that they have prolonged expiratory wheezing. It's a noise that you hear on expiration. Their inspiration may take a second, but then to exhale may take up to 3 seconds. You may also see retractions and nasal flaring in smaller children, and then SATs less than 95% are considered hypoxia. Now, hypoxia, the major causes would include perhaps a patient trapped in a fire. In a fire, there are noxious gases to include carbon monoxide. Carbon monoxide has a much stronger affinity to the hemoglobin molecule than oxygen does. So if a person is in a fire and they breathe lots of carbon monoxide, it will replace the oxygen on the hemoglobin molecule and the patient will suffocate to death. Now, if they're still alive when you pull them out of the fire and you do a pulse oximetry, it may tell you that the pulse oximetry is 100% because a pulse oximetry cannot tell the difference between carbon monoxide, carbon dioxide, hemoglobin, or methemoglobin. So a pulse oximetry is a good device if you know what it's telling you. And the only thing a pulse oximetry tells you is that what percent of the red cells that you have are saturated with a gas. It doesn't tell you how many red cells you have, and it doesn't tell you what the gas is either. If a patient has emphysema, we'll learn about chronic obstructive pulmonary disease, which includes chronic bronchitis and emphysema. They may become hypoxic, and they may chronically be hypoxic all the time because of their disease. A patient that overdoses on a drug that has a depressing effect may also have slow breathing as well, particularly opioids like heroin. If the patient's having a heart attack, if the heart isn't working appropriately as a pump, that can lead to hypoxia as well. When a person has inadequate breathing and we identify that, we have to restore normal ventilations. So we have to provide artificial ventilations to the patient. It's easier to do it if the patient isn't breathing at all, but if they are breathing somewhat and that breathing is inadequate, it's a challenge to ventilate your patients. You have to time the squeezing of the bag with them taking a breath in. By using a bag valve mask, we're able to supply supplemental oxygen to the breathing patient and increase their oxygen content. So I guess the question is, when do I start bagging a patient? Excuse me, I always say bagging. That's an old term. We bag groceries. When do I ventilate a patient? For me, it's if I see those signs of impending respiratory failure, then it's definitely time to start ventilating the patient. Initially, in a patient who is short of breath, you may start off with an oxygen cannula or oxygen by mask, but at some point, if they don't improve, you may have to assist their ventilations. So initially identify the adequacy of the breathing. If the breathing is not adequate, then we need to intervene or they will become hypoxic and die. So let's look at positive pressure ventilation. Positive pressure ventilation is forcing air or oxygen into the lungs when the patient has stopped breathing or they're not breathing adequately. It uses force exactly opposite of how a body normally draws air into the lungs. The negative side effects of positive pressure ventilation is that if I ventilate them too fast, I can fill their chest up with air and trap that air inside their chest because I never give them time to adequately exhale if I'm constantly squeezing the bag. That will cause a drop in cardiac output and a drop in blood pressure. If I squeeze too fast with too much force, you have a tendency to dilate the esophagus, and the air then goes down into the stomach as well as into the lungs, and then over time you have this big balloon in your stomach. Your stomach is completely full of air, which may precipitate vomiting. It also makes ventilation more difficult because the diaphragm can't flatten with that big air bubble in the stomach. Hyperventilation is a side effect that we need to avoid at all costs. It was demonstrated in pigs that when you ventilated them on average of 22 breaths a minute, you rose the pressure inside the chest to the point where it shut the blood supply off or collapsed the superior inferior vena cava and supplied no blood to the heart then at all. So you literally can hyperventilate somebody to death. So don't ventilate a patient who is vomiting or has vomit in their airway. The positive pressure ventilation will force the vomit into the patient's lung, will cause them to aspirate it. And again, even something as small as a teaspoon of aspirate can cause a pneumonitis that could lead to an aspirate pneumonia that could be life-threatening. I know I'm ventilating my patient enough. I know I'm providing enough tidal volume because I see the chest rise each and every time I squeeze the bag. And then I want to make sure that I'm ventilating them at an adequate rate. If the patient is short of breath, they may be ventilating shallow at 32 times a minute. Well, if I'm assisting their ventilations, I don't want to match every breath. Otherwise, I would be ventilating them at 32 times a minute, and that's way too fast. At most, I would want to ventilate my patient once every 6 seconds. And that would give you about 10 breaths a minute. Oftentimes doing that with 100% oxygen will slow their breathing down. So assess the adequacy of the respiration. Is the chest rising and falling adequately? Are the lungs clear? If you need to assist ventilations, explain that procedure to the patient. Put the mask over the patient's nose and mouth, and then after sealing it to the patient's face, squeeze the bag during the patient's inhalation. CPAP and BiPAP, it is within the scope of practice in Iowa for you as an EMT to administer CPAP with medical director approval and training. CPAP is continuous positive airway pressure, and unlike bag mask ventilation that we would provide with a BVM, with CPAP we can provide continuous pressure, both inhalation and exhalation. Bag valve mask ventilation just provides pressure on inhalation. It doesn't provide any pressure on exhalation. The importance of providing pressure on exhalation is that if the patient has to breathe against pressure, it stents their alveoli open so that they don't so that they can exchange more gas and get better oxygenation altogether. BiPAP is not something you can do as an EMT. It's not within your scope of practice. BiPAP is bipositive airway pressure or biphasic positive airway pressure. With BiPAP, you still have pressure on inhalation and pressure on exhalation, but the pressure on inhalation is greater than the pressure on exhalation. With CPAP, the pressures are the same, but with BiPAP, the pressures are different. And the reason for this is that, let's say you've got a COPD patient who's been working really hard to breathe and may need a little assistance taking that breath in. That's where BiPAP becomes more important. CPAP or BiPAP, that's not ventilation. They're not ventilators. When I put somebody on CPAP, they have to be conscious. They have to be breathing on their own, because CPAP will not ventilate the patient, nor will BiPAP. Mouth-to-mask ventilation occurs when you use your mouth and a mask to provide oxygen to a patient in respiratory arrest. If the patient does not have a suspected spine injury, you're going to position yourself at the top of the head. You're going to apply the mask to the patient. The pointed part of the mask goes on the tip of the nose. You can place your thumbs over the top of the mask and your index fingers over the bottom of the mask, and then rest your remaining fingers under the patient's jaw. This is called the C&E technique. There's also another technique out there called the Thenar technique, and that's where you take just your thumbs and place them over the top of the mask, and then use your remaining 4 fingers to grab the jaw and lift it up off the back of the throat. So lifting that jaw to the mask lifts the tongue up off the back of the throat, and then that allows you to have your partner squeeze the bag. One-person bag mask ventilation is not recommended, but when you're doing mouth-to-mouth, that's something you can do by yourself. You get that good seal with both hands, and then you use your own lungs to ventilate and make the chest rise in the patient. So here's a picture of the Thenar technique, where the person is using their thumbs along the top of the mask to seal it to the patient's face, and then using their own lungs to ventilate the patient. Now, a bag valve mask is a handheld ventilation device. It's used to ventilate non-breathing patients in respiratory distress or respiratory failure. It comes in a variety of sizes depending upon the size of the patient. Some standard features that you'll see with bag valve masks: it's a self-refilling shell that is easily cleaned and sterilized. It's got a non-jam valve that allows oxygen to flow into it at a rate of 15 liters per minute, and it's got a non-rebreathing valve on the end that attaches to the patient, so that the patient isn't allowed to rebreathe their CO2 when they exhale. You plug the bag valve mask into your wall outlet and you crank it flush, which is at 15 liters per minute of 100% oxygen. The oxygen then fills the bag as well as the reservoir off the back end of the bag. And then when you squeeze the bag, the air inlet is closed and the oxygen, 100% oxygen in the bag valve mask, as well as the oxygen in the reservoir, are delivered to the patient. And then when you release, the patient is allowed to passively exhale. 2-rescuer bag valve mask is recommended by the American Heart Association if you're going to give ventilations, because the most difficult part of bag mask ventilations is maintaining a good seal with the mask. Now, when you practice this in the lab, you may be able to do that once or twice with a mannequin, but that's not a person. That's not bouncing down the road. That's not the patient vomits. That's not facial hair. There's a lot of things that make one-person bag valve mask very difficult. So it's something that 2 people should do. So the one person, maintains the airway, and the other one squeezes the bag. If you don't suspect trauma, there's no reason you can't do a head tilt chin lift maneuver. Select the adult bag for the adult patient. Know that there's 1,200 milliliters of air in that bag. And if my normal tidal volume is 500 milliliters, I really only need half the air in that bag. So what you want to make sure you don't do is just randomly, on every patient that you try to ventilate, squeeze the entire contents out of the bag into the patient, because that'll overinflate their lungs and it will increase gastric distension. And here they're just talking about the picture that they showed earlier of the fingers on the patient's jaw and around the mask. Now, if I don't suspect trauma, I can open their airway as I do anybody with a head tilt chin lift. And then one rescuer holds the mask to the face and the other rescuer squeezes the bag. Here's opening the airway with trauma jaw thrust in those patients I suspect of trauma. And use the remaining fingers of your hand to pull the jaw towards the mask. Your helper will squeeze and let go of the mask in order to ventilate your patient. So here's a thenar technique where you have the thenar muscles of the thumb holding the mask to the patient's face, and then the remaining four fingers grasp the angle of the jaw and lift it upward and out. The second rescuer there then is squeezing the bag, watching for chest to rise and fall, and as soon as they see adequate rise of the chest, then they need to quit squeezing the bag. With the one rescuer BVM, again, it's just not recommended, and I certainly wouldn't even practice it. There aren't many people that can do it correctly. Again, you may be able to do it in a lab. You may be able to do it off and on. But to do it each and every time you squeeze the bag to provide that minute volume, that's what's important here. If the chest does not rise and fall during bag mask ventilation, you should look for a reason why the patient's still obstructed. First thing I do would be reposition the head. Maybe I didn't have it positioned right enough, and I didn't have the airway I didn't have their airway open. Listen around the mask for air leaks. Look at your bag valve mask system to make sure that it's not obstructed. And if all else fails, use an alternate method like mouth to mask. Now, when you have a patient who has a stoma or a hole in their throat, you may need to clear those mucousy secretions by suctioning in the stoma and then leave their head in a neutral position. And you might have to put a pediatric mask over the stoma in order for them to ventilate, because an adult mask can be too big. If the patient is not breathing, you can cover the nose and mouth and ventilate or breathe right into the stoma. Now, a flow-restricted oxygen-powered ventilation device, also called a manually triggered ventilation device, uses oxygen under pressure to deliver artificial ventilations through a face mask that you put over the patient's face. It's for adult use only. EMTs, at least in Iowa, services don't carry this flow-restricted oxygen-powered ventilation device, which is also known as the demand valve. And that is because when you trigger the device, it delivers 100% oxygen at 40 psi. Well, it's very difficult to get a sense of lung compliance, and you can fill the lungs too full and actually cause barotrauma by its use. So here's a picture of that manually flow-restricted oxygen device. An automatic transport ventilator is something else that you can do as an EMT. It provides positive pressure ventilations, and typically it's just two buttons that you can mess with if you've got one. One button is the respiratory rate button, and the other is the tidal volume button. And typically it'll deliver 300 for a child, 500 to adults. It'll deliver like 12 ventilations for an adult, and somewhere around 18 or 20 ventilations for a child. And it's your responsibility to know who is which, so that you can put the proper settings on there as you attempt to ventilate your patient. All right, so that is part one of airway. And if you have any questions, you know how to get a hold of me. And I'll be talking to you soon, going over part two.